Welcome. Today we have a very special guest, Dr. Kim Korba, DO. She's a private practice family doctor who has her own practice, her own solo practice, which is kind of like being a unicorn these days. But she is in a very specific position to talk about the healthcare situation, the healthcare system. She has a very great, interesting perspective. Kim is the owner of the Green Hills Direct Family Care practice, the first direct pay practice of family medicine in the Lehigh Valley. It's a trend that's going through the United States right now, so we're going to talk a little bit about that. Kim has also been very involved on the local, state, and national level discussing direct patient care, but also advocating for doctors and the doctor-patient relationship all along. So with no further ado, Kim, thanks for coming today.
Oh, thanks for having me.
I mean, you're in a great position for this because you've been, as I said, you're kind of, walking the walk, talking the talk. We, in a time where practices, especially primary care practices, are being eaten up by the big hospital systems around. You've been steadfast on what you're doing. Obviously, it's almost easier to give up and go with a hospital. What makes you feel so passionate about what you're doing?
Well, I always wanted to be independent. I always wanted to run my small business. When I started the practice 15 years ago, I think it was right at the last moment. I got in right under the wire where it became almost impossible for a doctor to hang a shingle anymore. So we had a few years of the early part of the growth, and then all of a sudden the insurance requirement regulations and the billing requirements started raining down on us. So I was fortunate to be able to open my own practice, hang my shingle, build it from 0 patients. But the reason I wanted to do that is because I wanted a small patient panel. I wanted to spend more time with them in the office, keep my overhead low, and things that I could control would allow me to run my practice. And also be a mom and have some flexibility in my schedule. So that went along fine. Things got a little tougher as time went on, and I did see my colleagues, my family practice colleagues, dropping left and right and selling to the hospital. It was probably easy for some and probably hard for some. And all of a sudden I looked around and I was one of the last men standing, or women. So in 2015, I was looking at the writing on the wall. The amount of regulations being tied to your reimbursement were almost impossible to achieve to a level of 100%. And they started tying your reimbursement. I was doing fine. The practice was doing fine. I was actually scoring really high. But every time you turned around, they were throwing another wrench in it, making it more difficult. And what I saw my patient time with my face-to-face time with my patients shrinking because of all the administrative burden. And that is not why I started the practice.
Exactly. So
I was getting away from my original plan with the practice due to factors I was not in control of. So I had, Rich Batista actually sent me a video in 2014 of Dr. Josh Umber, who's in Wichita, Kansas, and he owns Atlas MD. And I looked at that video a year before I decided to transition to DPC, and I remember watching it thinking, no way, this is too good to be true. And I almost had to just put it aside because I can't even believe that this exists, in this crazy insurance and all these regulations. So in the summer of 2015, when I started seeing that writing on the wall and knowing that I might not be able to keep up with the administrative burden and keep my overhead low and stay open, and most importantly, treat my patients the way I wanted to.
Right.
Because this is all about the patients. And I looked at the video again, and I said, that's it, I'm doing it. So literally in 3 months, we transitioned the practice from taking all insurances except Medicaid to direct primary care. So I opted out of all of the insurances and transitioned.
How's it going?
Great, it's going great. I wish another DPC would open in the Lehigh Valley. So I'm still the only one, but I really think it's a regional issue because we are surrounded by 2 large hospital systems that have bought up every family practice, and they can't, they have restrictive covenants, and I've heard from several who would like to do it but are limited in their ability to do it because of their contract.
Right. Let's talk about what you're saying, the writing on the wall, because as you know, OAA is still, it's the only independent orthopedic group.
You guys are a unicorn too.
You're
a bigger unicorn.
We're bigger unicorn,
bigger.
but that's the thing. The thing is, with all the regulations that came through, especially with the Affordable Care Act, the administrative burdens, the electronic medical record, and how long that takes to interact with, and the need to bring in scribes, and the need to bring in more and more, and then the more regulations with hospitals and insurances, and with authorizations and things like that. The time frame, the amount of time that a doctor is spending with the patients in some of these larger hospitals or larger group systems has gone down from maybe 70% of your time to about 25% of the doctor's time is face to face with the patient, and the rest of it is some type of either entering or typing into the medical record, or doing some administrative calling for authorizations and things like that. So all those things have been a burden that I understand people needing to go almost to the bigger giant that has all these things to work with
the
them.
support system for the
But again, as you said, you've always cared about that face-to-face time with the patients and that time spent. And you've done a few other great things. You've actually got, direct pay for lab tests and for your patients as well. So they're not paying the same prices at you would at the hospital labs or like that. You've been working those deals for your patients as well.
Well, that's what direct primary care is. We get rid of the middleman, and the patients directly associating or by their First Amendment rights and with us. They're contracting with us, and it's like a Netflix membership. With that, you get unlimited visits, prolonged visits. My visits are at least 30 minutes. We can go longer if we need to. If a patient calls with 5 issues, and Sarah, my MA, tells me, I said, okay, let's book her for an hour or an hour and a half. I've done a PAP, a physical, and addressed acute issues all in one visit.
Right.
You can't do that with the insurance companies. And that was one thing I got sick of toward the end, with not only the shortened visits, but people would come, they'd wait in the waiting room. We all were running behind just because of the craziness of the system. They'd wait in the waiting room, pay their copay, then come in and have 10 minutes with me face to face. They'd have 5 problems. I would have to quickly identify which ones I thought were the most important to triage first or to treat that day, and tell them that they'd have to come back for the rest. They were taken off from work, and didn't want them to have to pay a copay a second time.
Right.
But that's what the system was morphing all of us. The primary care, again, it's awful.
Well, I've always thought, in primary care, what does a primary care do? Everything.
Yeah, with the jack of all trades. Yeah, everything.
And so, to be expected, I know what I need to do just to get a MRI, order in, the hoops I have to, and sometimes 25 minutes on a phone talking to somebody who's not my peer, trying to get something authorized. It must be refreshing that you're not going through that at this point.
We still have to pre-authorize some things, but because we're only, we have a smaller patient panel and the visits are prolonged, my office staff has more time too. So we do still have to do them, but not as much. So even though I've opted out, when a doctor opts out of insurance for direct primary care, we can still order things through the insurance, and the insurance will pay. But those pre-auths do still come up, but it's not nearly as onerous as it was before. I'll call the specialist even while the patient's in the office, sitting in the office with me. If there's an issue, I'll pick up the phone. They love it.
Right.
And we solve that problem right while they're there. Somebody's creatinine's going up, I call nephrology, and
That's great.
Patients are really liking it.
So, like I said, you've been involved on the state and the national level about getting this fight through. And so we always, when we talk about what can we do to make healthcare better, You're doing that. You're doing this one patient at a time, and it sounds great. Looking at the whole system, and even if it's just a little piece of the pie, you've spent time in senators and congressmen's office. You spent time. What do you see sometimes you get a bunch of doctors together. It's like, oh, you just need to do this, this, and this, and everything will be fine. What are they doing? Why are they making this so complicated?
Right.
But I know, you're starting to develop a callus on your forehead from knocking your head against the wall sometimes. So I want to talk about that a little bit, about your experience. First of all, thank you for doing it, because doctors need to do that. Because our voice is probably the smallest voice when it comes to, we don't have the lobbying that the hospital association does, that the insurance association does, that DMEs and equipment companies does. But we still have the interests of the patient-doctor relationship as the most important thing. So, what do you see as some ideas and some things that either the patient that we're talking to today could be doing or thinking about, and where the fight isn't fair and where it should be made fair? Where do you see that?
Well, there are several physician advocacy groups, and there's some overlap, but a lot of them have their own little niche that I think physicians should get involved with, at least, and if not, donate money so they can go to Washington and lobby. I've been there with them. And the patients, I think, need to just stay informed, and they can actually follow these groups on Facebook and see what's going on. There's articles, statements being posted, lobbying efforts being posted, responses to proposed legislation being. So it is a lot to digest. There's a lot of balls in the air right now.
Right, and that's the problem. I think there are so many balls in the air, and the issue is no doubt incredibly complex. But there seems to be some simple things. Some of the things that we deal with is trying to get the price for something. The price for an MRI.
Well, that's the whole.
The price.
It's not transparent.
So it's not transparent. So, and there is a bill. There's a bill,
transparency
HR
bill.
4808.
Yep.
And it is literally 1 page long.
That's all it needs to be.
That's all it is.
That's all they need to be.
And it has been introduced, and it's been in subcommittee for a long time. Basically, what all it is that everybody, including healthcare facilities, providers, insurance companies, just shows the price.
I think, Rob, the free market, people are starting to shop their prices. The public is going to force this. I mean, it would be great if Congress passes something, but the public's going to force this. I mean, I just read an article yesterday. The amount of people with high deductible plans is at 50% this year.
50%.
Yes. So, if they have to pay out of pocket, they're going to shop for the best price on an MRI or blood work. The facility has to part with their insurance, which is another thing the insurances are doing.
Right.
They're saying you can't go to that facility even though that MRI is cheaper. You have to go to the one we're on par with.
And what's amazing about that, you still have to pay your deductible.
Well, so suppose they want to go to facility A and the MRIs. I can get an MRI cash price between $300 and $500 depending on the body part. Right. Suppose they want to go there, and that facility will charge their insurance through insurance, say $1,000, not cash, but $1,000. But facility B is on par with the insurance company, and they have an agreement with facility B to charge $3,000 for the MRI. So the patient, if they went to facility A and got billed, the insurance got billed $1,000, it would be a smaller proportion that would go to their deductible. But because they have to go to facility B.
And in what way and in what world does that make sense?
No, it doesn't. There's no other industry, and we're the providers of the care.
Right.
Without us, there is no industry.
Correct.
And we have no control over what our services are costing our customers. Our customers are our patients. And we can't control what we charge them. And so if Dr. A is better than Dr. B and Dr. B charges more, people are going to go to Dr. A. So that's the cash exchange, the transparency, and you got to let it fix itself.
But the other side of that is the hospitals.
Yes.
And so within the hospitals, if you are a a doctor that the hospital pays your salary. Obviously, you're expected to, to refer within that hospital. And they say, listen, it's all about continuity of care. That they're on the same medical record, so that I send somebody for an MRI. That MRI shows up in my medical record, and then it's just better for the patient. So what do you say about that?
Well, being on an electronic health record that is not connected to anything but my office, there's no data mining going on, it's all private. It is not hard for us to get an MRI result faxed over. So I can understand, and that was all part of the Affordable Care Act, and when HIPAA started before that, they were gearing us up for the electronic records and the exchange of information. But if you're not in a hospital system, St. Luke's and Lehigh Valley's system, I don't know, they might be talking to each other now. No?
No.
Well, so...
They are the same provider. They're both Epic.
Okay.
Which...
So they're picking up the phone and calling each other for results anyway. So I understand the whole point between the electronic record, but it has not. It's created more problems than it has solved. The only thing it has solved is that entities have data.
Right. And the problem is the whole idea was to have that data, so we can have best practices.
And
can control costs and all that. But
costs have gone
up. Costs have gone up. Incredible. I just looked at I just have an article from it was yesterday about United Healthcare stocks. Okay, hit an all-time high. Up about 16% this year.
Darn, I wish we had bought some.
So one of the things that I always say, funny, the whole thing was to get control of costs and to allow for access, or actually provide coverage for everybody, universal coverage. But if the costs are so much, if the deductibles are so much, where are we going?
Right.
I mean, and so the burden still comes on the patient themselves.
Right. So how did we get to this point? The common denominator is the cost. That's why direct primary care exists, because of the cost and the repercussions of the high costs and how it affected our ability to care for patients as primary care. It's affecting specialties, right? So how do we get control of the costs again? And why aren't they paying attention to that?
Well, I think follow the money. I think you could follow the money when it comes to lobbying.
Right.
I think
there's no doubt.
One of the things that you see is, and what I know a lot of doctors groups are fighting for, is neutral site payments.
Yes.
In other words, this is what an MRI of the knee costs, no matter where you are.
Did they pass that yet?
They didn't.
Not yet.
And the transparency, I see those two things as as a free market idea. Again, from the hospital standpoint, they're saying that they need higher reimbursements to provide the care that they do, because they give a lot of free care and that. But like you said, the bottom line for the healthcare crisis right now are a couple things. One is cost. One is access to care. Okay, just because you have coverage doesn't mean you have access.
Right, coverage does not equal care. We say that all the time.
And that is the worst part, because we have patients, again, $10,000 deductible or up to $15,000 deductible. For some people, they can't afford that.
They don't have that much money.
They can't afford $1 into the system to present to the system.
We say people are paying 3 times for their health care. They're paying their premium, their deductible, and their co-pays. And what are they getting for it? Not much. I mean, what else would you spend this much money on to get a product like this? And this is your health you're talking about. This isn't just a car. So it has to rein itself in at some point. And we're not seeing Congress move very fast on this. We're not seeing the states, they're digging their heels in on certain states are. like ours, on certain changes. So, it's going to we're believing it's going to have to come from the bottom up. The consumer, the person purchasing the product,
Right.
is going to have to
demand it.
Yes. Yep.
I'm trying to think, and again, Pennsylvania, I'm trying to think of why on the state level it would be such a problem. And again, I'm asking you because
What, to control costs?
to control costs or to the transparency issue, the point of service issue. Why?
Transparency would force down charges.
Okay.
And that's going to hurt the bottom line of who.
No, who?
The insurance companies and the hospitals. And our state has quite a presence, an insurance company presence. And, there is a lot of lobbying in Harrisburg, too, from the big ones.
Right.
So there's a lot of people made a lot of money in the past 8 years. And it's hard taking a lollipop away from a child.
So okay, so I'm Joe Public, okay, and I want to see what my congressman, who is providing funds for their campaigns and stuff.
You can go online. It's all transparent.
It is.
It's open secrets.
So that's the one thing that is transparent.
Oh yeah, it's open secrets for Washington, and I forget. You can just Google.
Okay.
It all has to be transparent. I've looked it up for my state rep.
So what do you see? Again, we're looking for answers here. That's why we're doing this podcast. I'm really. I've been spending the last 4 months researching and trying to research from everybody's standpoint, from the insurance company standpoint to the government standpoint to the patient advocacy standpoint, which I totally understand. And what we have to see is, okay, what is possible? What is possible?
Well,
to start with, what is a simple thing that most people get around? Most get their hands around.
I think doctors should be allowed to practice without anything really hanging over their heads. So when my grandfather graduated from medical school in 1941, he and his classmates were told to expect to do 10 to 20% off the top charity care. They did it happily.
Right.
We can't do that now. We can't waive copays. Oh, I can. I don't have to do it
Right.
anymore. But when I was participating with insurance, you couldn't waive copays. You were in breach of your contract.
Not only that, that's part of the payment. That's part of your whole payment to the doctor to run their practice.
You're foregoing money for the benefit of the patient if they're really having a hard time.
Right.
But you're also breaking why can't I decide if I'm not going to take that $30 copay if somebody's strapped that month? So those things have been taken away from us. There's definitely a portion of the population that needs charity care.
Right.
There's no doubt about it. But we wouldn't be having this discussion again if the costs weren't so high.
Correct.
So we could provide charity care, lower the cost. What's driving up the cost? Well, there's lots of lovely things driving up the cost.
Well, let's go through them.
Oh, CEOs, administrators' salaries. Everybody's seen the graph with the 45-degree slope up of the administrators. How much they're making.
Funny you say that. Funny you say that. There was just another. I'm trying to remember who it was, but one of the CEOs of a device company. Just his salary just came in at $23 million.
There was just an article. I think it was United CEO got a huge bonus.
Okay.
Yeah.
And so so again, there is that chart, the chart you're referring to, between 1990 and 2015. There's been about a 200% increase, double the number of physicians in the country. There's been a 3,000% increase in the number of hospital administrators.
So, to put that in perspective, before I decided to do DPC, I broke down my numbers. I went back to my billing and my collections. From 2007 to 2015, my collectibles, not what I charged, what I brought in, went up 5%.
Okay.
In 8 years.
Okay.
Right. So, where's the inequity there? Because I'm the one providing the service. You're the one. The doctors are the ones providing the service that is making these companies all this money.
Well, I always found it really interesting when, being on the board of our practice, every year we fight for insurance for our 125, 150 employees. And every year it goes up. But I assure you our reimbursement doesn't go up as the provider.
Right. Yeah.
It's like, okay, guys, where's the problem here?
Yeah.
And every year, you're adding more staff to go through the all the regulations and make sure all the T's are crossed and I's are dotted, and make sure that the authorization, make sure the burdens that are. I understand the reasons we did all the things. I think, in no doubt in my mind, I think the Affordable Care Act came from a good place for many of the people that wrote it. I won't say all, because there's a lot of money to be made.
Well, the objective was to ensure more people
covered, and I think that's great. I think
But if the cost wasn't high, we wouldn't have needed it.
Correct, and they did nothing.
Nothing to stop.
Nothing to stop the cost.
So now we have almost a full decade of more of this.
Right.
And it hasn't helped anybody.
And I just and that like I said. So what again? You have sat with a group of 80 doctors in a committee with congressmen and senators on the national level. Obviously, there's a lot of talk going on. Obviously, they're, I'll say, hearing, if not listening, the doctors. Have you seen any change? Have you seen any progress in that?
Well, I think that once the Senate comes back next week, well, they have to go through Senator McCain's funeral, and then I think the Kavanaugh confirmation has to go next, and then they're going to hit the floor running. I think they're going to be careful before the midterms, not to pull the plug on too many things.
Right.
I think after the midterms, before the end of the year, we're going to see a lot. They are paying attention to direct primary care. There's an HSA bill to allow. Right now, you can't fund your HSA if. I know.
Which makes no sense.
No, you can go buy
explain what an HSA is.
Chanel
explain what
glasses,
explain what an HSA is.
Health savings account.
Right.
So, if you have a high deductible plan that meets certain requirements, your deductible has to be a certain amount or higher. You can contribute pre-tax money into an HSA account, health savings account, and you can withdraw it tax-free, and it can grow tax-free. So it's triple tax-free money. There's nothing else in the country that exists like it.
Right.
And the growth of HSAs has been tremendous, and it follows you from year to year. It could follow you from job to job, and you can use it past 65 to pay your Medicare premiums. But for some reason, you can purchase all these other things, but you can't pay for a medical service membership with a direct primary care office. And that was in 2014. Then Secretary Koskinen made a statement that he felt that DPC was a second form of insurance, of health coverage, not insurance, health coverage. So that disqualifies it from being able to be covered by an HSA, or allowing a patient, if they purchase a second health plan, it disqualifies them from their HSA. Now, don't get me wrong, people are paying with their HSAs, and we tell them, this is between you and the IRS and your accountant and your lawyer. It's not legal yet, and people are like,
well, it seems so unfair not to.
After for $50 a month.
I mean, I know, like you said, people will buy $500 pair of glasses, and that goes to their HSAs.
$50 a month for same day or next day access for acute appointments, prolonged visits, coordination of care, access to inexpensive labs, and dispensing the wholesale generics. So we're saving them so much money, and they won't let the people pay with their own tax money. Their own money, not their own tax money, it's their own money for a medical service arrangement.
And again, that's just a legislative switch.
That's right.
And what's holding that hand from switching?
Well, yeah, there's a lot of special interests.
And that's what people have to pay attention to.
They don't want, we are the epitome of the free market movement right now. And, 2 years ago, it was growing, but in the past year, DPC is all over the news now. Compared to when I opened 3 years ago, I had to educate everybody. Nobody knew what it was in the area. Now everybody really knows. So they are paying attention, and they don't want free market to succeed, because we're holding a mirror up to the costs and saying, look what we can do with our primary care, how affordable we can make it for people. My rates are between $10 a month and $100 a month based on age. That comes out to 33 cents a day, all the way up to $3.33 a day. People spend more on their Starbucks than that.
I can't even get started at Starbucks.
So how can the government look at that and
Right.
say people can't pay with their own money that their pre-tax money?
That makes no sense.
It's insanity.
That makes no sense. So I want to go to another. Again, you mentioned it before, and you said, listen, there is a certain portion of the population, be it 10%, be it 20%, that really have the need to be covered and taken care of.
Absolutely.
And so they talk about from everything from the most extreme to like Bernie's universal health care, really universal health care. I did actually read that whole bill, and down to people just giving pro bono work. And how do you see that? I mean, again, we do have a Medicare and a Medicaid system. Is that a cost issue as well? Should that be made?
Yeah, they're losing money because the cost for the care that they're paying for again is so high, and who is setting those costs? As an example, there's about 300 physicians in the Direct Primary Care Alliance, and I looked at there's some demographic data that they haven't published yet, but I was told I could talk about this. 83% of the doctors on there give some form of charity care, but we have the choice to do it, and we do it happily.
Correct.
I don't have anybody telling me who I can and can't charge, and we don't broadcast it. It's done quietly in the office, and we're happy to do it. But with Medicare and Medicaid, you can't. Doctors can't even give charity care if
Correct.
they want to, if they're contracted.
Correct.
And then those systems are losing money because the costs are so high. It's
the administration costs. It's the set fees to certain, the different fees. Again, that site neutral payment would again bring all that down.
Well, and certain areas
people don't realize that say a private practice PT versus an institutional owned PT.
Higher reimbursement.
But the Medicare will pay 3 to 4, 5 times more
to the hospital
to that than to an individual.
The public doesn't know that. That is something the public needs to know.
And that's again one of the reasons why we're doing this is I want people to know that. The other thing is, and people say this a lot, is there is doctors in this country do well overall. I mean, better than most people. We are reimbursed very well for what we do.
Depending on your specialty.
Well, no. What I'm saying is that you're not.
We're crying the
professionals.
blues. Yeah, and we're not crying the blues about our income.
And per doc, per specialty, maybe we even make a little bit more than they do in Europe. What people don't understand now, and what I see is a real problem now, is docs are coming out now with incredible what they owe.
This is my fourth year of having third-year medical students rotating with me, and I've heard as low as 100,000, as high as 300,000 in debt, and I don't know
kids
how
that are
they're
graduating. I can tell you this: the average kids that are graduating with orthopedic residencies are somewhere around 300,000. So rather than going to private practice, where they have to basically build a practice, a lot of the young graduates now are going to an institution.
Well, they have to pay their loans
because the institution could pay, premium to take on these docs,
right?
And that increases the cost there. And one of the things that I think we could do, I mean, I don't know if you've heard this, NYU.
Oh, wow. It was all over.
Free.
Yeah.
NYU,
well, it's because somebody
NYU Medical
was generous
School.
enough to grant.
Correct.
Yeah.
But what's going on in Europe also? In Europe, let's say England. I mean, in England, people talk about the national healthcare system in England. There's a lot of problems with it, but I understand the good parts of it. The average person that gets to their internship, it's only 5 years of training, okay, because their medical school and undergraduate school is combined to about a 5-year program.
Right.
They pay about $10,000 a year. $10,000 a year for their schooling. So they come out with about $60,000 of what they paid for their education. The average public school, all in, is around $25,000 a year here, and the medical schools are another almost $50,000, even public. And so there's got, if they're gonna, and what I saw that in, what I really wanted to pay attention to when I was reading the Bernie bill was just that. I said, okay, you're gonna set what doctors can make. You're gonna set what doctors, what certain residencies they can go into and all this kind of stuff. Nothing about the education part.
Right.
Now, okay, who's going to pay for their education?
Part of me says anybody who's profiting off of the care of health should have a tax that goes to medical school tuition. Because, again, without us, they're not making money.
Exactly.
Yeah. Part
Exactly.
of me says tax them.
But again, we're probably the least strong lobby. I mean, doctors, the reimbursement for physician and provider services is about 8% of the healthcare costs.
Of the
about
total
8%
dollar.
of the total dollar.
So
it's 8%.
8 cents out of everything.
So even if you cut 20% or 25% of what we make, you're only bringing it down to 6%. You're only taking a 2% difference.
Right.
And nobody's going to spend 16 years in training to be reimbursed that way. So again, there seem to be such simple things like introduction of like there's military tracks. I almost joined the Air Force to pay for medical school. Fortunately, I was lucky enough to have some loans and some scholarships and didn't have to go that way. But there should be a lot more community-based services. And then you could staff clinics and teaching hospitals and those kind of things. But nobody's talking about it. There's no like doctor-centric initiatives and doctor-centric ideas that are being initiated.
And they should be calling us to the table more than us beating down the door to get to the table.
Right.
That's
a great statement.
That's a symptom of the past decade of us not being at the table. But doctors traditionally, we just want to go to work and take care of our patients, and that's stressful enough. But to have to be able to fight for the way you practice, that's a lot of extra energy, a lot of extra time that we would rather be in our office seeing patients.
I'm sure the patients would rather spend that time with us as well.
So we weren't at the table, and these things started falling down on us so fast, I don't think anybody had time to stop it. And there's a lot of heavy lobbying, like we both discussed in Washington, and that's hard to fight. And doctors, by nature, are hard to corral. It's like herding chickens.
Well, we're working.
Yes, we're working.
We're working.
That's right.
I mean, I know what you average. I know what your husband averages. I know what I average a week, and it ain't 40 hours.
No, it's not 40 hours.
Not even close.
No.
And so it's we're trying to. We don't. Any time that we take off of that, and that's why I'm here. That's why I'm doing this, and that's why you were here, and that's where you go. But I do understand, after a 60, 65 hour, 70 hour week, it's hard to then go out and take time away to. I mean, you spend a lot of time in Washington.
I've been doing charts on the train.
So you go back and forth, and that's God bless you. We love you for doing this, and I wish everybody would. But I think, the only thing that's going to preserve that doctor-patient relationship is doctors and patients.
That's right.
Making their voices heard. And I think, patients just need to be just so much more informed about what's going on. Where's the money? Where's the money going to? Why can't we get control of the money? Why are CEOs making the money they're making in the healthcare industry? Why are the profits in United Healthcare higher than they've ever been?
And I think people are paying attention because in the 3 years since I've been open, I have seen more people in my practice either choosing like a self-funded plan, like a sharing plan, a health sharing plan.
Right.
There's some that are denominational, there's some that are not. And or going with a super high deductible. I have one family, $30,000 deductible. They don't.
$30,000.
They don't put anything through their deductible. They're happy to come for the care
Right.
with me. They use all my cash prices. They're like,
So it's more of a catastrophic care.
right.
Okay.
Well,
which
what
is
we
really
had.
what it used to be.
That's what we had, and my
Right.
dad said you bought a rider if you
Correct.
need anything, just like your homeowners. You buy
Correct.
a rider for your jewelry or.
Correct.
So-
Listen, I remember going to the doctor's office, my mom writing a check.
Yeah, mine too.
And then
It's like $20.
And then my mom getting the paper for her to send to
Submit.
the insurance
Yes.
company.
Yeah. Yeah.
What happened to those days? You know, but I'm just to think about the amount of staff that.
Well, that also engages the patient and makes them accountable.
Right.
They have removed the patient from the equation too. Like they don't have any part in the decision making. So when you're, like when I was taking insurance, I'd say to the patient, well, your insurance won't pay for an MRI of your knee. We have to fail physical therapy for 6 to 8 weeks. I don't know what it is now. And
Cha-ching.
and anti-inflammatories. Oh wait, your creatinine's high. We can't do anti-inflammatories, but they still won't approve your
Right.
MRI. You still have to go through the physical therapy and just survive with Tylenol. Well, the patient's like, well, wait, I'm paying for my insurance a lot,
Right.
and I don't
And
want to
you
go
as
to
the
PT.
doctor are making the determination that physical therapy may be even harmful.
Well, harmful and more expensive.
Right.
Because now the patient's got to pay for copays to physical therapy, and then they're going to fail and then get the MRI.
Right.
Why don't you let us make that decision? And guess what? I have cheap MRI, so we don't have to worry about it.
Okay.
And then we have cheap physical therapy. There's cash. I know
There's
you
ways
guys,
to get. There's ways to do it.
I know you guys have independents that you refer to that are doing cash for physical therapy, and the patients love it.
Because we have to. Because again, especially that January, February, March, when nobody has met their deductibles, they're panicking.
Oh yeah.
They're
yeah.
panicking. I mean, it's one thing again if you have a savings account or that you make a.
Well, why should that
fair
have
amount-
to even tap into their savings?
I'm not
Right?
saying I'm not, and I'm saying it's
know.
bad.
Yeah.
I'm just saying there's people that, sometimes I think the people making the decisions have never been in the position of
No.
who they're laying those decisions on.
That's right. Yep. So a lot of that's where I'm seeing the patients, like I was demonstrating before, making decisions. Some of them are opting to go with no insurance, and DPC is not a substitute for insurance. We tell everybody they have to have some kind of major plan. But I've had patients who have said, I'm just dropping it for the year. I'm going to wait and see what happens next year, and I'm just going to keep my fingers crossed. And there's specialists out there doing cash pay, so if they need to go to somebody, that's what it's less expensive for them than buying the insurance.
Again, unless it's catastrophic and something happens.
But everybody
then-
gets nervous when they
Correct.
don't have a policy.
No doubt.
So
And there was a law that you had to have
yeah, not
a
anymore.
policy. Yeah, I know.
The employer mandate, that's a whole nother discussion. Because the employer market's the biggest market out there.
And I could tell you, each year, we'd love to give higher raises to our staff, but we're chasing the insurance.
Yep.
And it's like, it's very hard. From the business standpoint, where the margins are low, we don't know what regulation we're going to get hit with
Right,
again.
or who's going to
so
cut
it's
your
so it's
reimbursement.
so believe me, sometimes there's, I understand why doctors sometimes throw up their hands and go, I'm just going to join the hospital. I'm just going to join the
Yeah.
big institution, and let them deal with it. I'm sorry to my patients that have to pay a little bit more, but my life is finally a little better.
Yeah.
Because it does, when you're doing your dictation on the or you're typing into the medical record, for me, it takes me longer to record. I can't type. I can't, so it's and to navigate around the systems.
It was easier. I have paper charts still in my office.
Okay.
They're not active. I just leave two
Okay,
there
right.
to show my medical students. They're like, wow.
Right.
I'm like, this is like looking at a dial telephone.
Right.
They're like, a paper chart?
Yeah.
And I'm thinking, this wasn't that long
Yeah, but
ago.
medical students and the residents have become scribes.
Yeah, but I know, but this isn't that long ago that
I
we
know.
had paper charts.
not.
But to
It's
them,
not.
it's a whole different world. So
Correct.
they're like, this is pretty easy to get through. I'm like, it was a lot easier than what we're doing
Exactly.
now. It was,
And I'd be all in if it truly made patient care better. If it made patient care better.
Right.
And it wasn't so onerous. It can't be, recording a patient visit can't be 300, 400 times more time that it would take
Right.
10 years ago.
Well,
And that's what it is. It's 300, 400, 500 times. And if it used to take you to dictate into a dictaphone 2 minutes,
Yeah.
a patient exam, and it takes you 10 to 15, 10 minutes or whatever to really complete a patient chart. It's, you're talking about
Well, and
hours
see-
of day
and see, like,
recording.
You and I are old enough to remember the way it used to be. And I graduated from residency in 97. That was the year they came out with the E&M coding.
Right.
But I trained and I moonlighted in offices where we wrote notes that had,
Right.
you didn't have to pay attention to a billing level. And that was the beginning of the downward spiral,
Right.
those E&M codes. And you can't, you'd had to change the way you wrote your note. You had to change the way you dictated. It took longer,
Right.
which is what you're talking about.
Correct.
And then came the the electronic medical records and everything else along the way. So it has just completely eroded our ability to provide the service the way
Right. And again, at what margin of increasing patient care, the benefit to patient care?
no.
And so far that hasn't been proved. Listen, Kim, we didn't even get through a quarter of I wanted to get through today.
There's a lot to talk
and
about.
we're gonna have you back.
Okay.
Because we need to talk about
Access.
legislation. We need to talk about access.
Cost of meds.
We talk about cost of meds. We have to talk about all that.
Yeah, I'll do it.
And
I'll come every Wednesday if you want, Rob, for the next 4 weeks.
So get ready. We're going to have a lot.
Just have coffee. I'll be good.
I really appreciate you being here, and I think it's
Thanks for having me.
just been really informative. Don't forget, Kim, why don't you how do we get in contact with you?
Well, you can Google me, Green Hills Direct Family Care, and it should pop up. We're pretty high on the SEO. We're the only direct primary care office in the Lehigh Valley. You can just look up my name as well.
Okay. She's great.
Me to
She's
leave my
great.
phone number?
What? If you want, yeah, absolutely.
Sure, the
Listen,
office
some
number.
people still use a cell phone.
Okay. The office number is 610-530-9155.
Okay. And thank you, everybody, for listening today. We're going to be doing this over the next several months and hopefully inform you. What I really want you to do is when you view this on YouTube or you view it through our websites or through our Facebook, please give comments. We want to know what you want to hear. We want to know what you didn't understand, and we want to know what comments you have to say. That's a whole part of the community we're trying to introduce this to. So I really appreciate Kim's time, and I really appreciate your time, taking time to watch this. And please stay informed, stay loud, and really only you can make the difference. So thanks for listening.
Thank you.